So I have to talk about medical management of MDR-TB. So management consists of diagnosis and treatment. So a little bit of diagnosis I'm going to touch upon, which is important from a tertiary care point of view, which we see in good practicing spine specialists, which all of you all are. So we all know MDR-TB is said to be present when the patient is resistant to both INH and rifampicin. So when should we suspect MDR-TB in a patient? So if there's no clinical improvement or there's actually clinical worsening despite 3 months of treatment, please think of MDR-TB. If no clinical improvement and patient is getting incorrect regime, or if the patient is on inadequate doses, please suspect MDR-TB. If there's history of irregular drug intake, if the patient is in contact with a known MDR-TB patient, please suspect MDR-TB. If the patient is a diabetic or HIV, suspect MDR-TB because there's problem of absorption of AKT. And therefore, even if the patients are taking drugs properly, INH and rifampicin is not well absorbed, and therefore please think of MDR-TB in such patients. If they are alcoholic drug addicts, of course, even if they tell us they are taking medicines, we know we may not be able to rely on them. So also suspect MDR-TB in them. And most important, if there's worsening of lesions or there's appearance of new lesions at the end of 3 months of treatment, and primary sensitivity is not known at the time of starting treatment, then as we said in the beginning, at the 3 months, we will be less inclined to call it paradoxical reaction, even if the patient is clinically better, and therefore please think of MDR-TB. So how do we confirm MDR-TB? So madam very nicely told us that AFB culture by TB midget is a current gold standard. We have excellent molecular tests available, but currently this is a gold standard. And when we do a biopsy, we have to send the sample for AFB culture. This could be pus, it could be granulation tissue, it could be a bone biopsy, and ideally it should be everything. Just biopsy everything and give everything to your microbiologist and your histopathologist, and probably inconclusive diagnosis will not be there. So we all know that midget AFB culture takes about 1 to 3 weeks to grow, then about 3 weeks more for sensitivity. So we will take 4 to 6 weeks to know what is going on. And obviously spine TB is a major disease, we can't wait for that long. And that is where molecular tests come in. So madam has very nicely told us about what the recommendations are as per the guidelines. I'm going to move a little more ahead because I'm into private practice. So are all of y'all. And let's see what best could be done in today's day and age for our patients. So we all know that AFB smear requires 10,000 bacilli to be present for AFB smear to come positive. Now, spine TB is a postbacillary disease. Where are we going to find 10,000 bacilli per ml of sample? That is where GeneXpert, also known as CB-NAT, came in, which actually revolutionized the diagnosis and treatment of TB, and that required only 131 bacilli per ml of sample. And it also told us in 2 hours whether rifampicin would work or not. So GeneXpert is fantastic. But whatever said and done, GeneXpert does have its own limitations. The most important limitation being that if MTB detected is very low, and if this shows rifampicin resistance, then there's a 50% chance that this rifampicin resistance is a wrong resistance. Also, if there is any mutation in codon 533, it cannot pick up. If there are mixed population, it cannot pick up. So basically, GeneXpert also had limitations for extrapulmonary TB. And this is where we got GeneXpert Ultra, which is an advanced version of GeneXpert with better MTB detection capabilities and more definitive identification of rifampicin susceptibility and resistance. So everywhere where GeneXpert was making a mistake, Gene Ultra was improvised to not only detect more MTB, but also give us a more definitive response to rifampicin resistance. And look at this, GeneXpert Ultra is 8 times more sensitive. So the patient needs to have only 16 bacilli per ml of sample, as again GeneXpert where you require 131 bacilli. And GeneXpert Ultra will pick it up. And therefore this test is ideal for spine TB or any osteoarticular TB, as we know it is a postbacillary disease. So in today's day and age, GeneXpert Ultra costs exactly the same amount as GeneXpert costs. The company Keyfoid, which has made GeneXpert, has also made GeneXpert Ultra, and they've stopped producing GeneXpert kits. So the thing is that our program is waiting to get over of the cartridges of GeneXpert that they have. Till the cartridges will not get over, they don't want to put GeneXpert Ultra in the program. But obviously we cannot wait like this. And if our hospital doesn't have it, then a microbiologist knows You don't have to buy a new machine. You just have to upgrade the program. You just change the version and you have it. And you need to buy new cartridges. So for spine TB, Gene Expert Ultra is something that you want to ask for. Okay, after Gene Expert Ultra, as I told you, Gene Expert Ultra will only tell us about rifampicin, and we have INH monoresistance in our country, and therefore LPA is very, very important. We have LPA first line. This is going to tell us about resistance to INH, resistance to rifampicin. It will also tell us if high dose INH will work or not. This is important because we've got shorter bedaquiline regime, in which it's important to know whether high dose INH will work or not, because patient is being given that. And this will also tell us if ethionamide will work or not, because it's a second line drug. So first line LPA tells us about so many drugs. The second line LPA tells us if the patient will be sensitive to kanamycin, amikacin, capreomycin, quinolones, high dose moxifloxacin. So as you can see, LPA tells you about 9 full drugs. And most important, some patients have mixed population. They have sensitive organisms and they also have resistant organisms. So LPA will also tell you if your patient has mixed population. So do Gene Expert Ultra. If Gene Expert Ultra works out, don't stop over there. Ask for LPA. Now to just tell you all that in Mumbai we have pyrosequencing also, which is the best molecular test available currently. It is being done in Hinduja. And we are basically sending all our patients for pyrosequencing. We have pyrosequencing MDR and pyrosequencing XDR. Pyrosequencing XDR tells us about every drug that LPA tells us about. It is more specific and more reliable than the other molecular tests because it is actually a directory of every possible mutation. And it's especially important if the patient is on treatment, because as the patient is on treatment, the organisms die, the cell wall changes, and therefore LPA may detect wrongly double population. So now coming to the treatment, whenever we suspect MDR TB, send the sample for AFB culture. AFB smear is a part of AFB culture. So when you ask for AFB culture, AFB smear gets done free of charge. And you also ask for Gene Expert Ultra. And once Gene Expert Ultra is going to work out, if the patient is not on treatment, ask for LPA first and second line. If the patient is already on treatment for more than 8 weeks, because you're in Mumbai, please ask for pyrosequencing because LPA will still give you wrong reports. Just because your hospital does not have it does not mean you will not do it. You cannot say patient cannot afford it because LPA costs 1600 rupees. And if your patient doesn't respond, you're going to operate on him, which will be 3-4 lakhs of rupees. So let's be little more sensible. We can't be penny wise, pound foolish, and we cannot compromise on tests which are important. After doing this, once we confirm MDR TB, we have to start our patient on at least 5 drugs that the patient has not taken before while we are awaiting the sensitivity report. LPA or pyrosequencing will tell you what to use, what not to use, because it's going to tell you about all the injectables, kanamycin, capreomycin, amikacin, if it works or not. It tells you if levoflox will work, moxiflox will work. If these are not working, it will tell you high dose moxifloxacin will work, because 800 milligrams of moxifloxacin is being used when normal levoflox or moxi doesn't work, but high dose works. It will tell you about INH, it will tell you about rifampicin, tells you about ethionamide, tells you about high dose INH. So you can tell you from LPA pyrosequencing, you know which 8 drugs to use or not to use, which is huge. And consultation with MDR TB specialist is mandatory. And if you want your patients to have good results, you have to refer to an MDR TB specialist, not a physician, not a pulmonologist, but a pulmonologist who specializes in MDR TB treatment. I want you all to know that treatment of MDR TB has completely changed. So whatever I have been telling you all every year for last 10 years has totally changed. So now MDR TB drugs have been grouped into 3 different groups. Group A has levofloxacin or moxifloxacin. The second drug is bedaquiline, and the third drug is linezolid. Group B is clofazimine and cycloserine or terazidone. Both are sister drugs. And group C consists of all the rest: ethambutol, delamanide, amikacin, etc., etc. Please note, ciprofloxacin, ofloxacin are not AKT. You cannot use them. Please note that currently kanamycin, capreomycin have been given up. You cannot use them as AKT. Also, streptomycin has become a very plus minus AKT. Only injectable you are allowed to use today is amikacin. You could use streptomycin if you already have a report from a reliable lab which is showing streptomycin sensitivity. Otherwise, if you use streptomycin, you could actually be sued because it is no longer counted as an MDR drug, not even as a TB drug. So what is really important is that first 3 drugs from group A should always be included unless patient is resistant to it. So if your LPA shows patient is resistant to levofloxacin, or the patient has already been on levofloxacin, then you can't use it. But otherwise, you use all the first 3 drugs, levoflox, moxi, and bedaquiline linezolid. You use both the drugs of group B, cycloserine and clofazimine. If one of the drugs of these 5 cannot be used, then you will use the group C drugs. Treatment should start at least with 5 TB agents which are thought to be effective. So patients should not have taken these medicines, and continuation phase has to have at least 4 drugs. So basically what drugs you want to start with? You'll start with quinolone. From the LPA or pyrosequencing, you know if to use levomoxi or high dose moxi, which is 800 milligrams. Bedaquiline has to be used. So you cannot send the patient to a pulmonologist who is not allowed to write bedaquiline. And bedaquiline is, after 50 years, we've got 50 years after rifampicin, we got a drug which can really kill the TB germ. We have to use bedaquiline in today's day and age. There is just no compromise here. The third drug is linezolid, fourth is clofazimine, fifth is cycloserine or terazidone. These 5 drugs have to be a part of your prescription unless LPA shows resistance to quinolones, or any of the drugs are not available, or the patient is like not tolerating the drugs, or the patient has been using this drug in the past. Also, if LPA is not available, use a quinolone, but don't count it as a drug and use a 6th drug. You understood, no? Like for example, GeneXpert showed MTB, LPA did not work out, so you're not sure about quinolone. So give the patient quinolone, but don't count it as a drug and give a 6th drug, because in India there is 40% resistance to quinolones for MTB. So order of replacement, if you can't use these 5 drugs, you will give delamanide followed by amikacin, PZA, ethinomide, PAS, ethambutol. Last will be meropenem, imipenem. This is how you are going to replace drugs to have minimum 5 sensitive drugs. When sensitive reports are available, modify therapy to have a regime of at least 5 sensitive drugs. Continuation phase, as I said, should be at least of 4 sensitive drugs. Intensive phase should be 5 months after culture conversion. So culture, you're not going to be repeating biopsy. So once your MRI is showing kind of healed disease or stable disease, then that way. And total duration of treatment, if using bedaquiline regime, then it's 18 to 20 months. But if you're not using bedaquiline, then it's about 18 months, 1.5 to 2 years after culture conversion is the total duration if bedaquiline is not being used. We have a shorter all-oral bedaquiline regime. I'm telling you all, please don't use it. I don't want to even talk about it, because we really have reservations about it working out. The results in trials are different, but the field results are extremely disappointing. Dosages, the best thing is now we've got chart. Weight is so much, give this dose, you don't have to think. Please take a photo of this, give this dose. Make sure your pulmonologist is giving this dose and not making a mistake. So I've given a lot of information. I'm like basically just saying everything in the form of take-home messages. Certain points we must remember. Never add a single drug to a failing regime. This is called addition syndrome. This is criminal. You are giving EHRs at the end of 3 months, MRIs plus minus, chalo streptomycin add kar diya, chalo levoflox add kar diya. Never add one drug to a failing regime. If you are thinking patient is not responding, do a biopsy, confirm resistance, start 5 new drugs if it is MDR. Diabetes and HIV are more frequently associated with drug resistance, and so check for them in people who are not responding well. Microbiological results have to be obtained from a good and reliable lab, most important. Microbiology is going to help us how to treat the patient. Please identify a good lab. I send everything to Hinduja, though I work in Bombay Hospital. Cross resistance between kanamycin and amikacin is significant. So basically we are not going to use amikacin, but a patient has already come to us on kanamycin, then you don't want to use amikacin unless LPA shows amikacin sensitivity. Also, there's complete cross resistance between levoflox and moxiflox. So patient who's failing on levoflox, you can't replace the drug with moxiflox and say it's a new drug. However, high dose moxi could still be working, 800 milligrams. So if LPA shows that high dose moxi is working, you could give it. Otherwise, you could give high dose moxi and not count it, because if you don't have LPA. Patient should always receive home supervised treatment, supervised by a family member, because many medicines, many side effects, who's going to take treatment for 2 years? We don't even complete 3 days of antibiotic course. How can we expect patients to take 2-year treatment? So somebody from the family should be monitoring treatment. Intermittent regime should never be given for MDR TB. You can't write amikacin 3 days a week. You have to give daily treatment, except for bedaquiline, which in the continuation phase is thrice a week. Once the results are available, the drugs the patient is resistant to should be withdrawn, and the patient should be continued in the final regime of at least 5 sensitive drugs for at least 5 months after culture conversion, and continuation phase is going to have at least 4 drugs. Monitor closely for bacteriological and clinical response and look for adverse reactions, because adverse reactions are more common with MDR-TB treatment, and drugs for MDR-TB should be continued for at least 1.5 years and ideally 2 years. So to conclude, MDR-TB poses a great challenge for treating physicians. MDR-TB is a pure laboratory diagnosis, not a radiological or a clinical diagnosis, and AFB culture by TB midget is a current gold standard for its diagnosis. Molecular methods like GeneXpert Ultra, LPA pyrosequencing for early diagnosis of MD-TB are highly sensitive and must be used in today's day and age. Duration of treatment for MDR-TB is at least 2 years and ideally 2.5 years. So to conclude, MDR-TB is a curable disease, and every effort should be made to prevent its upward march on charts of global mortality. Thank you.